Well, good morning, everybody. Welcome to our Frontiers lecture today. I'm Jim Ford in the Division of Medical Oncology, and together with Steve Artandi, are very pleased to introduce this morning's speaker. Many of you know, of course, Judy Garber, who's the Susan F. Smith Chair at the Dana-Farber Cancer Institute and Chief of Cancer Genetics and Prevention at Dana-Farber and Professor of Medicine at Harvard Med School. So Dr. Garber graduated from Yale Medical School with an MD and an MPH in epidemiology, followed by training in medicine and in oncology at the Brigham and Dana-Farber. And importantly, was a fellow in clinical epidemiology there in the NCI, working with Drs. Fred Lee and Joe Fermani, of course, and helped understand the genetic basis of the named Lee-Fermani syndrome and the hereditary basis of cancer risk due to p53 mutations, very important in the field. She joined the Harvard Med School faculty and the Dana-Farber Breast Oncology Group, where she directs the Cancer Genetics Division and was appointed a full professor in 2011. Judy has many awards and honors. She's elected member of ASCI and AAP. She's the past president of the American Association for Cancer Research, AACR, and serves on the National Cancer Advisory Board and was elected to the National Academy of Medicine in 2003. So of course, her research, as we know, focuses on clinical cancer genetics with a focus on breast cancer risk and genes, and really has played a huge role in the developing area of clinical cancer genetics as an area of specialization in medical oncology, and has had a great role in influencing those of us in this field. So she's been a great friend to us and my colleagues here at Stanford over the years, and the more than 20 years since we started our program, really based on her model at Harvard. And so I'm delighted that she'll be talking to us today about unexpected consequences of expanded germline genetic testing. Judy, thanks. And remember, at the end, the questions will be submitted through the Q&A box.
Thank you, Jim. And thank you, Steve. And I will try to share my screen now. Hopefully this will work. Maybe it will work. Okay. Okay. I think this is working, right?
Yep.
So it's a great honor for me to speak in this series at Stanford. I'm only sorry I can't be there, although I will say that it is finally spring in Boston today. That's a day-to-day assessment, but today it is. It's lovely. And so it makes it a little easier. My daughter went to Stanford undergrad, and we realized that the year she was there, when we came out for the 6th time, because every time we went anywhere, we thought, oh, it's not that far from California. At the 6th time, she said, that's enough. So, but we know how beautiful it is and how amazing an environment it is and how many wonderful people are there. So I came up with this title, which I should probably make the first and last apology of the talk, but it is actually not completely inaccurate. So I do have some, let's see, some disclosures. Unfortunately, only one of them, Helix Genetics, pays any money. The rest of them don't. And most of them are research consolidations. But my spouse, fortunately, does get paid for his work with Novartis. So next generation sequencing, you all know extremely well. It had a lot of consequences in the breast cancer genetics world and the cancer genetics world. And I am not going to give a lot of background about all of this stuff because you all know it and live in it. But we realized after a while that, you know, instead of doing a gene at a time, which those of us who are really old, which is probably mostly me at this point on this, at this setting, but we used, you know, when this started, BRCA1 and then BRCA2 came along, and TP53 was at the same time, but it was not easy to get it done. The testing labs weren't really set up, and we only tested people who looked like they had Lee-Fermani syndrome, which we'll talk more about. And when multi-gene panel testing came along, of course, it was more complete, more efficient, less expensive. It made it much easier to think about doing testing more broadly. Not that we don't rely on family history, but it made it possible to think about testing less selected populations based on family history, which is all we had to go on before in thinking about inherited risk. It enabled the development of cell-free DNA, so not everything required tumor testing. And it allowed us to think about other mechanisms like mosaicism because it was so much more sensitive than the previous iterations of sequencing. And these were all things that in genetics one might have thought about in theory or theoretically that there ought to be mosaicism, but we really hadn't seen much of it. Well, we weren't looking. So this is from a relatively old study of breast cancer patients at Dana-Farber who had given blood allowing it to be used for research without restriction. We didn't return any results to them. And it just reminded us when this first came to be, you can see the date was 2016, not that long ago, that if you tested a population of patients, you would start to see genes beyond BRCA1 and 2. And of course, in this cohort, there were no TP53 genes, and I'm going to talk about Li-Fraumeni for the first part of this talk today, but there were low prevalence of other genes that fortunately Dr. Kurian has spent time helping us learn how to deal with and to manage. This is just an example. If you look in a cohort of patients, which we did looking at about 3 years worth of breast cancer patients, just asking what happens if you test them broadly instead of testing for even restricting genes by disease, so the panel of genes for breast cancer, what will you find? And will you find mutations in other genes that would make you think it was worth taking a broad look instead of a narrow look at patients, whatever their clinical indications? And you can see in this that we had about 2% of our cohorts had mutations in genes that you can argue you might have wanted to know about, even though they had nothing to do with breast cancer. And only a third of them had any family history to suggest that these were there. So the truth is, if you do testing in any population with large scale gene measurement, you're going to basically be doing population screening and you will find other mutations. So is that a good thing? Do you do this because it's your opportunity to do testing? It's unlikely you're going to get insurance to cover testing very often. And so maybe this is your chance to find mutations you might not have thought about. Maybe you should automatically add ovarian whenever you do breast, but Lynch syndrome and some of these others you might not have considered. So this is not a value judgment lecture, but it is just to remind us that, of course, this will happen. And the fact that you can do this technology means that you're going to find germline test results in any analysis you do, whether or not you're primarily looking for the germline. And these were the data that Tom Slavin and Jeff Weitzel looked at with Garden, I believe, showing that in the midst of their cell-free DNA, there certainly was detectable germline mutations. And they are thinking these days about how to handle that when you ordered their test. But what I wanted to talk about today with a little bit was Li-Fraumeni. So I suppose that this is in some ways, a confession of the field that we really allowed ourselves to be, to live by the selection biases that we had for a long time, and that's changing now. And the fact that it's changing is probably an example for other conditions as well. So Fred Lee and Joe Fraumeni up here were the first to describe Li-Fraumeni syndrome and call it Li-Fraumeni syndrome. There's always obviously some controversy about it before. And their question was this a syndrome? Because it was different from others in the diversity of tumors that might have been present. And then came the link to P53, which was in 1990. So we're going back a ways now. In fact, there was the 50th anniversary at ACR, one of these a few years ago. And then looking at what is Li-Fraumeni, what is the spectrum of disease. So here's classic Li-Fraumeni syndrome with childhood cancers, multiple primaries, sarcomas, early breast cancers, adrenocortical carcinomas, brain tumors, the classic Li-Fraumeni clusters of component neoplasms, and families that are generally devastated by cancer. So no one would argue that this was Li-Fraumeni or would be surprised to find a germline TP53 mutation. And there have been a number of criteria set up to describe, to improve the classification of Li-Fraumeni syndrome. wondering, do you always have to wait until there are 3 affected individuals? In the classic definition of Li-Fraumeni, there had to be 3 people, first-degree relatives of each other, one of whom had to have a sarcoma, diagnosed before 45, all of this. And then the French group really has led the way to look at other potential tumors that might be part of this. And there have been other variants that have aimed to help you find Li-Fraumeni before it had to meet all the criteria. So looking at Form-Fruste or earlier diagnoses. And among the features of Li-Fraumeni that called everyone to it were the diversity of tumors, the early ages at diagnosis, the high rate of multiple primary tumors, which meant you had to survive some of the early ones to get to the multiple primaries, and a clustering even of second tumors in early years, and the differences between males and females, that females have always had a higher rate of cancers, even during childhood, although they certainly increase further when breast cancer becomes the predominant female tumor, and men just continue to develop their tumors over time out later into their lives. So we've learned a few things. So for example, the British group actually was the first to study breast cancers in Li-Fraumeni and ask whether they were different. And they were different in that they were really clustered as ER positive and HER2 positive tumors. And the other, there are several other series now. And the interesting thing about this, of course, is that TP53 as a somatic mutation is virtually required in triple negative breast cancer, but there's very little triple negative breast cancer in Li-Fraumeni. And there's very little P53 mutation in ER positive HER2 negative breast cancers, but there's a lot of that in Li-Fraumeni. So it's interesting. Now, although I didn't make a slide, there have been 2 recent publications, actually maybe 3. The first large one from a Spanish group, and then just most recently from Josh Schiffman's group in Utah, looking at lung cancer in Li-Fraumeni and showing that 89% of them are EGFR positive adenocarcinomas. Smokers, non-smokers, that's what they get. I don't think anyone yet knows why that's true, since TP53 is a pretty ubiquitous mutation in many different lung cancer subtypes. And the early data all said these were bronchoalveolar tumors. But I think if people get a little bit older, they're getting their adenocarcinomas. And so we need to figure out why these things are true. So we were interested in this question, and we decided that one way to look at this issue of what was going on in Li-Fraumeni syndrome was to look with one of the testing labs at a large cohort of patients who underwent testing partly now as multi-gene panel tests, so that's MGPT, as compared to single gene testing, which you can imagine people might have had done if they looked like Li-Fraumeni, if they had family history already, if they had family history of P53 mutations, then of course they might be in that group. And this is just to show that, you can see where the entry of multi-gene panel testing really came in and began to take over for single gene testing. So this was looking with Ambry genetics at the time. So this is a couple years ago still, but about a 45,000 person data set where the number of TP53 mutations is relatively small. Now, that's partly true because some people prefer to have customized data sets in which they don't include TP53. That was Memorial for a long time. They didn't want to deal with it, but I think they have since relented and now include it regularly like everybody else. But this was just the distribution of single and multi-gene panel tests with TP53 positive results. And you can see that they were obviously much higher in the single gene rate of positives, and that this was just the breast panels because they obviously could occur in any panel. They were just more frequent in this group with a larger denominator. And of course, as you'd expect, the making criteria, the more restrictive criteria would be much more likely in people with single gene testing than multi-gene testing. And that was true for men as well as women. There just aren't very many positive men in this cohort. And of course, there aren't that many men in the cohort, relatively speaking, altogether, because most genetic testing still is in women and most of it is still in breast cancer patients. But so there is still some selection in this world. So this is just the cohort overall, showing the predominance of women in both groups and the different ages at genetic testing. So there is an older cohort here. Most of our positives are in the younger age, and the distribution. and then the single and multi-gene positive rate for males and females combined, and then for males and females separated. So you can see males were even higher because to get tested, men in general looked like they must have had much more history. So in this cohort, there were 118 distinct mutations. They were in both groups, but most of them were in one or the other. That just tells you that there are only so many at this time frequent mutations, although there certainly are some. The most common identified in total were dominant negative mutations. We'll talk a little bit more about that. So just looking by test type, by age if you prefer, the reds are always a single gene and the multi-gene. And this was an issue because, you know, we have looked for so long at Li-Fraumeni families that look like that example I showed you where everybody was diagnosed young, even with their multiple primary tumors. But you were starting to see TP53 positive results in individuals who were older at their diagnosis of any cancer at all. And this is not just breast cancer, this is anything, and here are the men showing their later onset disease. So they just are people who wouldn't have been sent for testing before. Here's breast cancer diagnosis where that was still true. Here's the distribution if you look at age of first cancer and some family history, and you still can show that the multi-gene panel tests are later than the single genes overall, and this looks like this because it's just fewer numbers. So what was good about this study was it was a lot of people, at least it was a large cohort. It wasn't so many positives in the end, but it was a reasonably large cohort, but it was largely driven by white women with breast cancer. And there was concern about what were the weaknesses in the data set. So one of the things we tried to do was to go back and look at what kinds of mutations these were. So this is a big issue in Li-Fraumeni. TP53 is not that big a gene, but there are a lot of issues in trying to figure out the significance of variants, whether they're loss of function or dominant negative missense mutations. Various groups have identified various subtypes as being more important or less important. The French, for example, have usually found loss of functions to be more frequent. In this cohort, we found dominant negative mutations to be more often. In the breast cancer group, loss of function mutations. I think this is just sorting for the cognoscenti, I guess, about which is which, but still struggling with what is the deal. You know, the part of the question, I think, among the weaknesses of the original Li-Fraumeni data was that, you know, if anybody who made Li-Fraumeni criteria had a TP53 sequence alteration of any type, you assumed it was significant because they had Li-Fraumeni syndrome. Of course, we now know much better that that kind of noise that you introduce into the system just causes trouble. One of the other issues then is how do you define what is or is not a significant variant? And this is a tool that was developed at Dana-Farber, but there are two others in P53 and now several in BRCA1 and 2. So this is just a technique at this point, I guess, to look at every possible missense mutation and try to rate it for its pathogenicity. This is the Phantom database, which works quite well if you Google Phantom TP53 without the O in Phantom. Otherwise, you get every other Phantom you can imagine that will come up in the Google. But you can look at this. So R273H is a very common, quite pathogenic mutation, judging by the severity of family histories. And you can see that it's rated right in the middle of the pathogenic zone here. R337H is the founder mutation in Brazil, and that barely comes up as pathogenic at all. But if you look at the epidemiology in Brazil, which has been done quite well in 2 areas of the country at least, there is clear excess risk of adrenocortical carcinoma, breast cancer, and other Li-Fraumeni tumors. So somewhere in here, this is a guide, but it's not yet a final determinant or a system that one can use with complete reliability to determine whether a variant that's identified is going to have pathogenic consequences. And the other thing that was recognized was really mosaicism, acquired mosaicism, clonal hematopoiesis. So one of the other gifts of multi-gene testing is that you can now be very sensitive and identify very low allelic fraction mutations. So here was a patient who was 73 when we saw her, had breast cancer at 61. certainly does not have a classically Fraumini family history and had a TP53 mutation that was positive in her blood, like all the other people in this cohort that we looked at, but not in her somatic tissue. So not in all of her tissues. So not in her, this is an eyebrow pluck from Jeff Weitzel's lab, but most people do skin biopsies and grow the fibroblasts to avoid looking at other blood cells. And she had, at the site of her sequence variant in her blood, she was wild type. So this was not germline Fraumini, at least this was mosaic of some type, and in her turned out to be acquired mosaicism. So this was identified now about 7 or so years ago with a couple of papers in the New England Journal. And many people work on this now, I'm sure there too. I live in Ben Ebert's institution, so we call this CHIP, or clonal hematopoiesis of indeterminate potential, compared to many other names. But this is an acquired mutation over age, usually at least in the hematologic space, which is associated with an increased risk of heme malignancies, but also, as I'm sure you know, predicts for adverse outcomes, risk for cardiovascular events and adverse outcomes for bone marrow transplants and lymphoma treatment and many other things. But this is another possible result of a TP53 blood test, so has to be distinguished now from germline TP53. So for that, we've looked at a cohort of patients. This is just a sequential evaluation of patients who've come to Dana-Farber with their TP53 pathogenic or likely pathogenic variant. And we got nervous about this, so we've started to systematically evaluate them. And so this was 84 patients, of whom 28 had presumed germline mutations because 4 had a Brazilian founder mutation. There's a Framingham, close to Boston, home of the Framingham Heart Study, has a sizable Brazilian community, and they have brought their mutation with them. There were 7 with a known variant and 17 who met testing criteria would have been tested for Fraumini and had a high allelic fraction. And then there was the group who you can see is twice the size of the other, where the question was this Fraumini or not? Could this be either classic mosaicism or ACE? And of course, we hadn't seen much classic mosaicism before. So 15 of these people were not, had not agreed to additional testing. 34 of them originally wouldn't have made criteria. And then we worked up the rest with testing family members, in some skin fibroblasts, in some tumor testing, benign tissue at the time of a tumor surgery, or other informative testing. And we did find that 18 of them were also germline, but there were classic mosaics in there. 9 were CHIP, 2 had lymphoma, and 5 we still haven't quite figured out. So just to show you the cohort, these are the series. You can see again, it's mostly female, although that could change. This is an East Coast distribution of patients getting genetic testing, I'm sure. Other cancer history, and then their whether or not they met Fraumini criteria, and you can see most of them did not. And then I'm sorry about the slide. I think it's really hard to see, but it basically just this, I brought this to show you that the distribution of cancers that most people had, predominance of breast, but many others. Although these are mostly adults, these are not children. And if this had been a cohort with childhood cancers, this would have been a very different result. But you can see that these match up. So the truth is that Fraumini is, I wouldn't say it's a mess, but it is certainly more difficult to define than before. At least we have to work a little harder to be sure that those TP53 results on blood tests are not all Fraumini in the classic mode. And that's still a challenge, because most of the laboratory test results that people get when a TP53 mutation is identified goes on to talk about Fraumini and its 100% lifetime risk of cancer, rather than any other possibilities. With Nadine Tung and her group, we published this flow diagram that basically shows what we did in our cohort. And these are just examples. So these are people, because it's just sometimes hard to know, this is somebody who actually is positive, although I certainly wouldn't have predicted that this would have been Li-Fraumeni syndrome with a positive result in a patient whose skin fibroblasts were positive. And here's someone else who at least was positive with relative testing. Now that I just told you about lung cancer, maybe we should have been less surprised than we were at the time. Mosaic pedigrees, so these would be what we usually see in our place are young women, very young women with breast cancer who have a low allelic fraction TP53 mutation in the blood. You know, you don't get allelic fraction, you have to call the lab to get that. They don't release it. It's not a standardized test, but you can find it. And then you can try to look at the tumor and normal breast tissue at the time of their surgery to try to characterize these things further. Just to say that, you know, we assume that there is de novo TP53 mutation, which you're also most likely to find early if you look more systematically. Otherwise, you'll wait till people have their multiple tumors or their first tumor now and get tested. This is from a French study where they did 500x testing so they could match up children and their parents when the child had a mutation and neither parent had a detectable mutation in the blood. But it all leads to the question then, what's Li-Fraumeni syndrome now? So is Li-Fraumeni syndrome this family who has obviously classic phenotype Li-Fraumeni? Is this family also Li-Fraumeni since this patient has his TP53 mutation and we tested him expecting to find Lynch syndrome, perhaps, but nonetheless. So is Li-Fraumeni the phenotype or is it the TP53? And if it's TP53, then what do we do with families that still look like Li-Fraumeni phenotypically, but don't have an identifiable P53 mutation? This is from a model that was developed by Wenyi Wang at MD Anderson with data from us and Sharon Savage at the NCI and Louise Strong at Baylor, I'm sorry, not at Baylor, at MD Anderson, where she spent her whole career. But anyway, a way of trying to predict whether a family will have a de novo mutation. I think the model has to be adjusted a little more now for the chip that you can find, but nonetheless, it just shows the recognition that many of these syndromes have more complexity than some of us might have thought years ago. And one of the issues that's really challenging at the moment is what is the, you know, is all Li-Fraumeni the same? Are there low penetrance versions of Li-Fraumeni? Because certainly that would explain why these adult onset families that most of the adult oncologists among us and geneticists are seeing look like they do compared to the childhood Li-Fraumeni. And is there, what's the difference? Is it the variants? Is it the penetrance of the variants? Is it a modifier? Is it something else? So this is a paper that does have contribution from Stanford in it. We share a family that is part of this work that's really headed by Kara Maxwell at the University of Pennsylvania. And she identified a variant, this is the variant that was predominant in families that were all Jewish at the University of Pennsylvania. And this is just two of the families featured in the manuscript. Then you can see that there are plenty of breast cancers, bilateral breast cancers, lots of breast cancers and other tumors. They're not so young and there's not really a childhood cancer at all. This is the family, in fact, that we share with Stanford. I don't know if that's a HIPAA violation, but it's been adjusted. But what makes me nervous about this family is that this part of the family, it meets classic criteria for Li-Fraumeni with 2 childhood cancers and a sarcoma and a multiple primary tumor. But in the next generation of the family, there's been only 1 cancer now, and it's not on this pedigree, and then an adrenocortical tumor with 2 men in between who've had nothing. So is this low penetrance Li-Fraumeni syndrome? In this family, it's a little harder to be absolutely certain, but certainly other families have looked like this. And the green marks here are for haplotype links. So Kara did show that they shared a haplotype. Now they're Ashkenazi Jewish, so that may be true anyway, but it was certainly true for this variant. And then she went further and tried to look at, can you say these are really low penetrance, where the green is the G334H, I'm sorry, R, I do that all the time, G334R variant, which shows later onset. A little surprising, this is the Brazilian mutation, but they don't get much that isn't breast or adrenal, as I said. So just trying to sort through some of this. So are we going to have to do this now for each variant and try to sort out whether it is or is not high penetrance, and what happens in a low penetrance family when more cancers start to occur? So there has been some discussion now about whether we should have a system of labels for Li-Fraumeni instead of calling everything Li-Fraumeni, or just how we're going to sort this out. So fortunately, we are now funded to look at this question of redefining the epidemiology of Li-Fraumeni syndrome. And this is our study, which is called Lift Up, and this is a shameless plug for the study. So Jim will talk at some point about trying to recruit the Li-Fraumeni families from Stanford to join the study as well. It's quite clear from our materials that you can be in more than one study, but we also are going to be approaching everyone who keeps these families to try to put together the largest cohort of Li-Fraumeni families from around the world that we can. And then, of course, making this available to the Li-Fraumeni community to address many different questions. So this is something that fortunately we're now funded to do. The second aim of the project is to look at modifier genes to see if that can be a way to try and sort out this, because we do a terrible job of individualized risk prediction in Li-Fraumeni. I think still is worse than in other conditions because of the range of tumors that can occur. And the third aim is actually to look at CHIP. So this is for TP53, however it's found. So for the last 10 minutes, to make sure we have time for questions, I was just going to talk a little bit about breast ovarian cancer. And since this now starts to feel like true confessions, where did we make mistakes along the way? Since probably it's foolish to say that any of these things were unexpected results of expanding data, because if you were thinking back then, you would have realized these things would come. And I am not going to do anything in the epidemiology or risk associated with BRCA1 and 2 because Allison is here, and why would I do that? You could just listen to her. But what I'm going to talk about instead a little bit is how we thought that we might try to approach DNA repair deficiency in the tumors that occurred in BRCA1 and 2 carriers, and why it took us so long to try to work through this question that we had before. So this is the slide that originally got our group at Dana-Farber, which was David Livingston and Dan Silver, who was working with him, Eric Weiner, the group at Mass General, the group at Beth Israel, who have always been great collaborators with us on all of this together. So we have shared many things that we've tried to do. But this was the original data at the time when there was only one triple negative BRCA1 cell line. And it just showed that this tumor was much more sensitive to killing by doxorubicin, by platinum, than it was either doxorubicin or paclitaxel, which were in those days, and still are, the standard for killing breast cancer cells, and was similarly true for radiation. George Sledge, who you all know, was responsible for some of the earliest work in platinum, and really showed that it was not a great drug in breast cancer, that it didn't have a very high response rate. It was developed at the same times as the taxanes, and except for HER2 positive, it really didn't seem to have a future. But based on the understanding of the function of BRCA1 and 2, particularly in double-strand break repair deficiencies, we went ahead and on the basis really of that cell line data, we did a single-arm neoadjuvant trial using cisplatin and not carbo, cis because that was what was used in the laboratory test. And we did a lot of translational work, which was good. It helped us fund it. And we did the study. This was only done at our 3 institutions. And in 28 patients, we had 6 pathologic complete responses and some other responses. There was an age association. And the thing really was that it was the mutation carriers or tumors that had low BRCA levels that had any response at all. So this emboldened us on the basis of these 6 responses to go ahead and try to do more in platinum. Now, Steve Narod took the protocol and did the real neoadjuvant study in BRCA1 carriers in Poland, where they had founder mutations and could do rapid testing in newly diagnosed breast cancer patients. And they published a remarkable pathologic complete response rate to single agent platinum 4 cycles in mutation carriers. And this led to work by Andrew Tutt, excuse me, in the TNT trial, which I think I forgot to include here, and also by the German group in the Gebhard-Sixto trial, adding platinum to the, first in the metastatic setting, showing that it worked only in mutation carriers and in breast cancer. And then in the Gebhard-Sixto trial in the neoadjuvant setting, where platinum was helpful, but only to non-mutation carriers. The mutation carriers did just fine without it. That led us to put together a study through the TBCRC led by Nadine Tung, looking at platinum and asking, was it better than standard AC or not? And this trial, this was the randomization of single agent platinum given just that way to doxorubicin, and then going to surgery with all of the usual structures for BRCA1 and 2 carriers. We originally targeted 170 patients. We finally closed the trial when we got to 118 and realized there just weren't going to be any more because there was too much else going on in the field. And so here were our 117 patients with 1 who withdrew. The patients were mostly BRCA1. They were mostly stage 1 and 2. They were evenly divided between nodal statuses. They were mostly triple negative, but there were 30% ER positives in there. And they, of course, were mostly high grade, as these tumors usually are. And what we showed, as we published last year, was that platinum was not better for anybody. That the neither the all patients, nor the triple negative patients, nor the ER positive patients, nor anything else could we show that platinum was better. And the response rate was a disappointing 29%. So we were fortunate, perhaps, in our first study that we thought we had selected this group of patients who should respond to platinum because of their DNA repair deficiency, but not in breast cancer at this time. Now, that doesn't mean platinum has no role, but it does mean that as a single agent, I don't think most of us would want to use it in breast cancer. In combination, it may still be helpful, and in patients who managed to have a previous breast cancer for which they had their anthracycline, which is used far less often today, platinum might be an alternative. And we've spent a lot of time trying to figure out, how we got misled and why, what this means and was this a bad thing. But so I don't think platinum is over, but it is interesting to speculate on why this happened. And I would say this is a common problem in breast cancer drug development, or maybe in drug development overall, where phase 2 trials often take people in directions they, in the end, wouldn't have gone otherwise. Quite different from the PARP inhibitor data, although even that, so here's Olympiad showing, fortunately, that there was an improvement in progression-free survival with the use of the PARP inhibitors that also target DNA repair deficiency, both in the Olympiad trial and in BRCA, the talazoparib trial, which is good because otherwise there might be no PARP inhibitors to be developed any further in breast cancer, though they were certainly effective and have been in ovarian and in mutation carriers otherwise. But we took this question one step further to ask, so okay, the stuff works in BRCA1 and 2 germline patients. Does it also work in anybody else with DNA repair deficiency down any of these pathways? And what about somatic acquisition of BRCA mutations, which is extremely rare in breast cancer at primary tumor diagnosis, but much more common as tumors become metastatic. So this is just the DNA repair pathway because it's obligatory to show one of these slides. So there it is. And now these were the results of that study, which we also published just at the end of 2020, showing that in our hands, the responses in the germline were all in the PALB2 patients, at least all of the significant responses were. And we did not see responses in CHEK2 at all or ATM. In our hands, these are barely responses. We had only a few other genes. There were some interesting genes. And on the somatic side, somatic BRCA mutation carriers responded. We only had one PALB2, two PALB2 patients. These patients were clearly somatic. They had to have a negative germline test. So this has been interesting. We're now in the expansion phase of this trial. You at Stanford have done work in slightly differently structured trials that have also shown PALB2 to be an important target. I'm not sure we should be surprised by that, since it was clearly identified because of its close interaction with BRCA2. But it has certainly led to some increased thinking about when we should be testing for PALB2 and at least not limiting our testing to BRCA1 and 2. In this study, also importantly, the ER positive patients, who were a large majority at this point, responded to PARP inhibitors, not just the triple negative patients, and even after their CDK4/6 inhibitor. So in thinking about future trials, this was useful. I put this in because this is Johan de Bono's paper, which was published in the New England Journal recently, and raises the question of just how these drugs are going to be developed in the future. Do we have to do this a gene at a time? Or can you do as he did and do sort of analyze things in groups, and that way be able to get an approval for the FDA for treating prostate cancer patients with any DNA repair deficiency gene mutation, whether acquired or germline, whether or not individually there might be data to the contrary. And I say this because their groups were interesting. One of the groups was BRCA1 and 2 in ATM, where they certainly had excellent responses, but actually none of them were in ATM. And yet still the way that this is now approved is a group approval. And so that raises the question of whether, you know, in breast cancer, we should not be trying to do this a gene at a time, or we should, and what the companies are going to want to do is another question. I'm sure we're all trying to think about this. This is Olympia, which we hope will be presented at ASCO now that the IDMC has released this. Olympia is adjuvant PARP inhibitor. And if this trial is positive, then we will be changing our testing, I suspect, at least from an indication of most metastatic disease to at diagnosis to consider using a PARP inhibitor the way it was in the trial, which was for a year after completion of all other therapy, except for concurrent hormonal therapy in the ER positive cohort. And then if that's true, then that will be an exciting change in breast cancer. Certainly this is already happening in ovarian cancer. And just for the shameless plug, this has nothing to do with surprises about germline testing, but maybe surprises that in Jeff Lindemann's data that rank ligand is an important molecule in the development of only BRCA1 associated breast cancer, not BRCA2. And this is a progesterone regulated molecule. And since most of these tumors are triple negative, it is still a bit of a mystery. In Jeff's data though, it's quite clear that if you inhibit rank ligand, that you can turn off proliferation in the tissue of the mice and also to some extent in human tissue. And on the basis of this, there is a phase 3 prevention trial using denosumab, which is the approved human rank ligand inhibitor. It's a randomized trial of denosumab versus placebo in BRCA1 mutation carriers willing to defer mastectomy during the period of the study, which is 5 years if they make it that long, with a planned dropout rate that should accommodate that. It's an international study. I'm the PI in the US, where we have a nice DoD grant to help try to work out the biology of all of this if it works. And I put this up because I certainly hope that we'll be able to convince you to participate in the study. And otherwise, I thank my group, our funders, and you for the opportunity to present today. Jim, I can try to find the Q&A.
Judy, thank you so much for an excellent talk. I'm just trying to turn myself back on here. I don't know how to do that. start my video.
Here you are.
There I am. Very good. Okay, so questions for Judy. If you type them into the Q&A, we will distribute them. While we're waiting, let me ask, so, you know, this idea of now, of course, like you, we're finding these various levels of mosaicism in leishmania. So for some, obviously rare, but some of these families that are true mosaics, tissue mosaics, and you figured it out because of a skin biopsy or whatever, but of course you don't really know which tissues are at risk. And so the idea of how you screen them is complicated, though, you know, over-screening them maybe is not wrong. But a really tough question that we get asked then is, you know, what's my risk for passing this on? So what's your or anybody's experience in trying, you know, to define that in ovary cells or sperm cells and you know, or what are the various approaches for dealing with that?
I mean, I think for males, it's a little easier to look at sperm and see if you can detect the P53 variant. For females, that's obviously more difficult, and it is often, I mean, it certainly happens that this will be there. I don't know how we're going to do this in the future, except to use PGD in the way that we do in the germline carriers, which is a expensive and challenging approach, but I don't think there's any way to sample ovaries to know this. And I mean, maybe in the future, if we can CRISPR everything and fix it all, it won't matter. But until those days, I share your frustration. It's very hard. You know, you feel badly having people have to have all of this very burdensome screening because you really can't tell where their mutation, which tissues are at risk. And it also, I'm sure you see this too, it's difficult because the other question we get asked all the time is, can you radiate them? So usually find them because they have a cancer diagnosis and maybe radiation is part of the treatment you would use under other circumstances. Can you do that safely if you're pretty sure that they're mosaics, but you don't really know which of the tissue in the radiation field might be sensitive? So it's a challenge.
Yeah, really tough.
Can I add
Lydia? I'm sorry, go ahead, Steve.
Oh, okay. Judy, wonderful talk, really thought-provoking. I had a question about, you know, P53. So we know so much about what it does. And, you know, it's the guardian of the genome, it's an inducer of cell death and cell cycle arrest. But I would say that we don't really even understand why P53 mutant mice are cancer prone. We don't know what it is, you know, what aspect of P53 function is it exactly that makes mice cancer prone? And then, so I'm wondering, you know, what is it about P53, do you think, or P53 haploinsufficiency that makes humans cancer prone? Because when you look at the tumor spectrum in leishmania, it's, you know, this hodgepodge of tissues that don't seem to have too much in common between sarcomas and leukemias and adrenocortical carcinoma and breast cancer. And I mean, some are dividing, some tissues are dividing, some are not really very much. So what are your thoughts on that question?
Afraid, I really don't know. I mean, we've always said, you know, sort of the only tumor that's not represented in leishmania has been like Ewing sarcoma. I think it's the only one you never see. Everything else is there. Mm-hmm. So, and it's been very difficult to have a functional assay for TP53. I mean, there are people who have certainly tried, but there's so many functions to TP53 that it's difficult to be sure that if you don't see one, that has told you that this is therefore not a significant variant. That would be helpful too. So I'm not even sure how to rank the functions, or that what would know. And I only feel better because, you know, there's a whole world of investigators who work only in TP53, and I don't believe that they know either yet, although not for lack of trying.
Well, I was intrigued by, I think you said that HER2/neu is frequently amplified.
It is in
right?
the breast
So maybe
cancer.
it's the permissive environment for amplification that P53 deficiency affords. I mean, that's one possibility. But then the lung cancer data that you cited, that's EGFR point mutation and not amplification, or do we know yet? I don't know.
There are both. I think they are amplified, but there are mechanisms of resistance. Some acquire T790M, some do not. Mm-hmm, I don't think that this has been fully sorted out yet. So I don't know if you can say that that's the reason.
It's really fascinating.
Okay, so Judy, Lydia Shapiro says hi and asks, what do you think the best model for delivering survivorship and primary care to patients with these types of increased cancer susceptibility?
Lydia, I apologize for not including that in the talk. I think it's a huge challenge. Leukemia is such a burden to families because it's so unpredictable. And even when you see families like the ones I showed, which are so adult in their diagnoses, you can't promise them that there won't be childhood cancers. I do think also that there's quite good data now that that there's a lot of burden to screening. Jim mentioned, this, that it's there's a word for it. It'll come to me in the middle of this, but where the challenge of trying to keep people from spending their lives looking over their shoulders all the time and trying to let them have their children grow up normally. It's really difficult. I think, Stephen, in Dicer 1, you have to test the children and you hope they grow out of their risk. Here, they grow into their risk, but there's still a lot of childhood cancer testing. I don't think I have an answer except that you really need a supportive team, because the problem for these people is that either the other shoe is dropping, or it has dropped before and it will again, or it will. And in these less penetrant families, I think we're all struggling with what to do with them. So they're not quite leaf-meaning, but we don't know how far off they are. Should they be having whole body MR or not? And whole body MR is, has not been, it's involved in one randomized study. I don't know if insurance will ever cover it. And I'm not sure, I don't know whether they should or not, but it's what you can do. So that was a really long rambling answer, Lydia, because I really have no idea. We all do the best we can. So study it, tell us.
Yeah. Other questions? Melissa has a comment. Let's see, excellent presentation. Such a tour de force through the many contributions to understanding germline genetics of breast cancer. Yeah, thank you, Melissa.
Well, everybody can have their 10 minutes back. I don't think they'll complain. Maybe it's only 8. So.
Can I ask you a question about modifiers? Because you talked about that a little bit, and that seems like that could be key, although maybe difficult to sort out. What approaches are being used? It sounds like a difficult problem, and how does one come at that problem?
Well, so fortunately, Chris Amos is the person on our grant who is responsible for figuring this out. And it is a challenge to try to think about using GWAS data from studies of particular tumors. So we can try to look at what Melissa's identified for brain tumors. We can look at lung cancers a little bit, although we don't have that many lung cancers in the cohorts. We can look at breast cancer modifiers. Mostly these are SNP arrays or GWAS. And you can, we will try. I think the best I can say about the grant is, we should have enough power to really look at a few of these in some detail. The community is really quite exceptional in its collaborative nature. Maybe that's what happens when you study rare syndromes. You know that from your own work with telomeres, et cetera. But, and if we're able to do that and really come together, then we will have a large group of families where everybody can do all their own special questions, and we can over time have more and more power and be able to sort this out. I hope. I mean, it's possible that we won't, because it's more complicated than that. I don't think we all think it's just genetics, and that's part of the problem. The environmental exposures.
Any information that the PRS scores that now, of course, are being developed in breast cancer and other things, that those breast scores would have any relevance to leaf-remaining, or is it really going to have to be its own GWAS set, do you think?
I don't know what to think, Jim. I'd be interested in your thoughts about that. I can't quite figure out those PRS.
Well, I think it's hard to know what to do with it in breast cancer already, and so it gets even more complicated.
Right. Yes, although at least they maybe their best value will be in modifiers for BRCA1 and 2.
Yeah, exactly, right. That's
so that
where I think it's clear.
Helpful there, if only that. But for leaf-mediated for such a small population, I think it's going to, that our best hope is to try to get everybody together. And if people honor their commitments, we'll have thousands of leaf-mediated patients, and maybe that will do it.
Yeah.
So it's, anything you want to do,
Hey, Stephanie Jeffries asked another interesting, relevant question about epigenetic changes that might serve as modifiers.
I think that's a really important area. The question for that's going to be, how much material can we collect so that we can look at that? A very interesting question on which I have even less to say.
What are your thoughts? Melissa asked, and I've talked with her about this as well. Of course, she's now shown POT1 as a risk gene for gliomas. And of course, they often have p53 as well. We were just talking about this week in terms of screening. What would you need to consider brain MRI, for example, these POT1 families, and what we've learned from leaf-mediated doing that?
Well, I think in in our data, which I didn't include because it's not quite ready, we've done okay in screening the brain. I would say that our biggest challenges are like lung, where I don't think MRI, the number of missed lung tumors that we have is way too high. We haven't missed anything in the brain yet. But I think there, Melissa, you have the problem that, gliomas that are slow growing, that may not be the aggressive gliomas. When do you want to find them? And how are you going to manage them? Some of them you can remove, and there's good data for the pediatric patients in leaf-mediated that that's an effective intervention. I don't know. I think, there where you can at least focus in one organ system, it might be a little less awful to be doing this.
Dan Camp has a question about your BRCA platinum data,
Yeah.
Comparing it to ovarian cancer, making the point that, for several years, they do appear to respond better. Why is breast cancer different in that situation? Is there a mechanism? Do we know?
We originally did this work because triple negative breast cancer and ovarian cancer shared so many features. And we thought this would be the same thing, but it clearly is not. And we actually now have a center at the Farber for, it's called with the terrible title of BRCA and beyond, but it's for looking at breast, ovary, pancreas, prostate, and across various gene mutations, because I'm sure there's more we can learn by the comparisons than because we were wrong in the way that we thought these things might behave. I don't know, I think that, and I don't mean to say that platinum doesn't work. Platinum doesn't work as a neoadjuvant therapy, that is clear, but that's not that there's no role for platinum. We've all used platinum in advanced disease and had it work in patients with mutations. And I think there will still be debate about whether PARP inhibitors, to some extent, are expensive platinums in some of their roles, but I think they're clearly more than that. And I wish that breast cancer was like ovarian in that setting and responded the way ovarian does many times, but I don't think we at least have not figured out why it's not the same.
Yeah.
Right.
Okay, well, if we don't have any other questions, or Steve, then I think we can wrap it up. Judy, thanks so much for an excellent talk and for joining us. We really appreciate it, and look forward to seeing you in person as soon as we can.
I hope so. Thank you.
Okay, thanks so much.
Bye.
Bye.